Good afternoon, good morning, depending on where you're at right now. Thank you, everyone, for joining us on our webinar for the ATS Clinical Questions Assembly. My name is Rodolfo Alpizar. I'm an assistant professor of medicine at Wake Forest University and a critical care physician at St. Luke's Medical in Milwaukee. Me with Dr. Illipparambil who is an assistant professor of the thoracic medicine and surgery at Temple University, will be moderating this webinar on a polygenic risk scores. First, I have the honor of introducing Dr. Moll, who is an assistant professor of medicine at the Channing Division of Network Medicine, an associate physician in the Division of Pulmonary and Critical Care Medicine at Brigham and Women's Hospital and Harvard Medical School, and a physician at the VA Boston Healthcare System. His research focus on using genetics and other omics in early identification and therapeutic intervention for individuals at high risk of chronic obstructive pulmonary disease, asthma, and pulmonary fibrosis, also the related outcomes. He has multiple awards, including the ATS section of Genetics and Genomics and the American Society of Clinical Investigators. Dr. Moll, thank you very much for accepting our invitation, and please go ahead with your presentation.
Okay, great. Well, thanks for that nice introduction. Here are my disclosures. So I just want to kind of start, why are we talking about genetics? And really, when we talk about complex traits, which are diseases that can't be explained by single genes, like monogenic diseases, it's really a complex interplay between genes and environment, right? And there's a lot of things that go in between just genetic variants and environments. But for respiratory disease, this is particularly important, of course, as we're exposed to all kinds of things in our environment. And so I kind of want to focus on COPD primarily here. And we hear this idea that not all smokers get COPD, with about 15% being the traditional number. If you look in cohort studies that are enriched for smokers, it's much higher, right? So it's more like 40 or 50% in our smoking cohorts. And we all, as clinicians, we're kind of familiar with this phenotype, these different phenotypes, right? So the 90-year-old woman who says, the key to living long is smoking every day, and she just has a cough. And then there's the 45-year-old man who smoked for 20 pack years and is walking around on oxygen. And so why is there this variation in susceptibility? It can be related to infections and exposures, but it can also be related to your susceptibility. And surprisingly, about 30 to 40% of the variation susceptibility can actually be explained by genetics. So while it's still a majority environmental, there is a substantial variability due to genetics. And there are a few monogenic causes, the most famous of which is alpha-1 antitrypsin deficiency. But when you look at kind of all the monogenic causes, you're still talking about less than a few percent. So not even coming close to that kind of 30, 40% mark. And so this is where genome-wide association studies, or GWASs, can help address these sort of questions. And so really briefly, the idea here is that you start with a population, you have cases and controls, and you say, I want to understand what are the genetic variants that give us susceptibility to this disease. And you genotype people, right? So you get their variants across the genome, and you literally just do a regression analysis, right? And it's a little more complicated than that, but essentially it's a regression analysis adjusting for confounders. And you'll see these plots. These are called Manhattan plots because they look like the Manhattan skyline. It's basically chromosomes on the x-axis, negative log 10 p-value on the y-axis, and then you get this dotted line here. So this is your genome-wide significant level. So this is just a Bonferroni correction for multiple comparisons for the number of base pairs in the genome. And anything above that level is considered genome-wide significant. And this has become a technology and an approach that has really improved over the years. So genotyping is like $35 now, right? And you're talking about blood test or a buccal swab that you can mail in, and you only need to do it once in your lifetime, right? So in COPD, our group and others have done GWAS. that have identified 82 loci associated with COPD and over 1,000 loci associated with FEV1 and FEV1 to FVC, implicating like over 500 genes and 29 pathways. So it really shows you the complexity of this disease. And the causal mechanisms, though, are a little bit harder, right? So each one of these, just because it's the lead genetic variant, that doesn't mean it actually is causing the disease. So that is like an entire kind of downstream set of studies on its own. But the other way that you can use genetics is for prediction. So ideally, you'd be able to predict who's going to be susceptible to the disease, like those smokers who do or don't get COPD, right? But individual variants actually explain a small amount of genetic risk. And the idea behind a polygenic risk score, or a PRS, is that you can take the genetic variants and pool them together and explain more of the risk. So in this model, it's essentially down here, you take the dosage, which is essentially a 0, 1, or 2, at least conceptually, and then you multiply it by a weight based on the GWAS summary statistics, and then you sum that together across the genome. So this was first really popularized in coronary artery disease. And so this is from this paper. It's very interesting. You look, this light blue line here is saying that using a polygenic risk score, we can identify 8% of the population that are at a threefold greater risk for coronary disease. So that's a lot, because familial hyperlipidemia has like an odds ratio of 3. And now you're identifying 8% of people in the population with that same risk for coronary disease, right? Based on their genetics alone. And the excitement around these scores has really been in that you can change the way you think about risk for an individual patient. So we have our traditional risk factors, you have your genetic risk factors, and then maybe there's some action threshold where you would do something like give a statin, right? But individually, the clinical or the genetic risk wouldn't get you there to actually take action. But when you combine them, it might push you past some action threshold. And in fact, there's this interesting analysis of a clinical trial with statins that showed that if you look at the overall absolute risk reduction for people who got statins, it was a 2.7% absolute risk reduction compared to placebo. But if you looked at people in the top genetic risk group based on a polygenic risk score, or PRS, you actually see almost an 8% absolute risk reduction. So the high genetic risk group is responding much more to the statin therapy. And so we wanted to do this in COPD. And what we did was we used GWAS summary statistics from 500,000 individuals in UK Biobank and Sperimeta. We tested it in about almost 30,000 people in 9 cohorts across the world. We have a forest plot on the left showing this, and basically for every standard deviation increase in the PRS, there was a 1.8 odds ratio for COPD in European ancestry individuals and a 1.4 odds in non-European groups. And then if we look at the deciles, so you take the top 10%, compared to the bottom decile, there's an 8-fold odds in European and 4-fold odds in non-Europeans based on their genetic risk. So pretty stark differences there. As a clinician, you wonder, well, why can't we just use family history instead of genetics? And family history is really a combination of genetics and shared environment. And so we did multivariable models with polygenic risk score and family history, and the main outcome was COPD case control status. And we found that actually they didn't really, when they were in the same model, they didn't attenuate each other. And we actually did formal causal mediation analyses and found that only about 12% of the PRS effects on COPD was captured by family history. So the majority of this is not captured by family history. We also found that if you have really high genetic risk and you smoke a lot, that's much worse than either risk factor alone. So here you have log pack years on the x-axis, FEV1 to FVC on the y-axis, and we see that the slope of the line in the first decile is much different than in the 10th decile, right? So if you're in the high genetic risk group, smoking is much more harmful. We also found that genetics is really more important earlier in life. So the PRS was able to predict COPD occurring before the age of 50. with a much higher effect size in both COPD gene and Framingham. And so the left is a smoking enriched cohort, and the right is a general population cohort. Now, I want to talk about this study real quick because so this was not from our group, and this is not about PRS, but what it is this was a randomized trial of case finding for asthma and COPD, where people were called, 1 million people were called, and basically 900,000 people weren't interested, but the 100,000 people who were interested were screened for asthma or COPD with a questionnaire, and those who were identified as having one of these two diseases were referred to an asthma pulmonologist with an asthma COPD educator, or just to usual care with their PCP. And referral to the pulmonologist and the educator actually resulted in reduced healthcare utilization due to respiratory illnesses. So we wanted to see, right, if case finding is actually really important for public health and for changing outcomes, can genetics improve case finding approaches? And so we took people who did not have a diagnosis of COPD, and we said, okay, we have a validated lung function questionnaire, which is a case finding tool, 5 questions based on symptoms, smoking, and age. And we looked at whether or not adding the PRS to this questionnaire was actually going to improve our ability to identify people who had moderate to severe GOLD 2 to 4 COPD who did not previously carry a diagnosis of COPD. And what we found is that, the AUC for the PRS was like 0.7, and then it goes up to 0.78 with the lung function questionnaire, and then 0.84 when you combine them together. But this effect was less significant in our smoking population. So it's really the general population where you don't have a lot of risk factors, and the younger population where we're seeing the difference. And we actually showed this in this paper, that it was really the discrimination improved pretty significantly in the lower age group. And then a couple other things. So PRSs more broadly, right, because this is really about chronic lung disease, and PRSs can give insights into the mechanisms of overlap traits. So in this study, we developed a PRS for asthma, and we looked at the COPD and the asthma PRS, and when we included them in the same model for asthma COPD overlap, shown as ACO here, we actually saw that both scores were associated with ACO, suggesting that these individuals not only share clinical features of both diseases, but they actually share genetic underpinnings of both of these diseases. So that was an interesting thing. And then the other thing that we can think about is, what about the genetics of other traits and comorbidities, giving us insight into the risk of COPD-related outcomes? So we're all sort of familiar with that cachectic COPD patient, the pink puffer, who's very frail. And one of the questions is their frailty, is their risk of poor outcomes, is it due to the fact that they've always had kind of low BMI and low genetic risk, or is there some additional cachexia beyond what you would predict based on their genetics? So we developed a score for BMI, and we identified people who had what we call discordantly low BMI, so more than a standard deviation below what we would predict their BMI to be based on their genetics. And it was actually this group in multiple cohorts we're showing here in these Kaplan-Meier curves. The discordantly low BMI group actually had far worse outcomes in terms of mortality. So just to kind of summarize, this is a broad overview, but it's really supposed to show how genetics can start helping us to understand how we can use them in chronic lung disease and for precision medicine. So we can identify susceptible individuals, we can identify high-risk subgroups, we can potentially intervene early because we can detect a disease occurring early. So this allows for risk factor modification. I think we haven't shown medication responsiveness yet, but the literature in cardiovascular disease suggests that it may be worth looking into. We can use it to identify undiagnosed cases. We can start to dissect shared mechanisms with other traits, right, like asthma, and we can understand COPD-related outcomes. And ultimately, we do want to be able to predict poor outcomes in these patients. So trying to understand who's at risk for certain things, why they're at risk, and what we can actually do about it. So I just want to acknowledge a lot of people here who have helped with this, and I'm happy to take any questions. So thank you for having me.
Thank you so much, Dr. Moll. That was fascinating. I neglected to share with the group that we'll be having a discussion and answering questions at the end of the lecture. So please share your questions in the chat and we'll address them as we're able to. Next is Dr. Gabrielle Liu. Dr. Gabrielle Liu is an assistant professor of medicine at UC Davis who specializes in pulmonary critical care medicine. Her clinical focus is on the diagnosis and management of interstitial lung disease. Her research interest is in respiratory epidemiology, population health, and preventive medicine. Her research focus is on prevention of COPD, chronic lung disease, and examining the impact of environmental exposures using novel biomarkers. Currently, she's an appointment member of the ATS Environmental, Occupational, and Populational Health Assembly Planning Committee. Thank you, Dr. Liu. Dr. Liu, I think you're muted.
Yeah, thanks. Yeah, so I was just saying, this talk is going to focus on proteomic risk scores in lung health. No disclosures. And so given that the focus of today's talk is on the use of proteomic risk scores in a population health context, I'm really just going to be delving into the circulating proteome. So our blood proteome is made up of proteins that are secreted into the bloodstream that orchestrate a variety of biological processes, both in health and disease, including hormones, cytokines, etc. As well as we have cellular proteins in our blood proteome, which are leaked into the plasma through cell damage and cell death. And again, since we're talking about proteomic risk scores that are developed in a population studies, I want to briefly touch on the tools that we have that enable this high throughput proteomics analysis that's really necessary to do proteomics on a population scale in thousands and thousands of people. So first you have mass spectrometry-based proteomics, which is sort of our classic method and methodology for doing proteomics, which originally would often identify hundreds to maybe a couple thousand proteins, but now using data-independent acquisition techniques, you can analyze all peptides within a certain mass charge range, including low abundance proteins, and that's compared to data-dependent acquisition, which selects only the most intense peptide ions, and that's really allowed for unbiased and comprehensive analysis, as well as high reproducibility and improved data processing speeds. However, really the high throughput proteomics analysis method that's most commonly used in population studies are affinity-based techniques. And so that's when protein-specific antibodies or aptamers bind to each target protein. And the affinity-based technologies that are most commonly in use today are the SomaScan and Olink assays. So within the SomaScan assay, your target protein is bound by a DNA aptamer, which is called a somamer, which can then be quantified using standard DNA quantification techniques. And then in the Olink proximity extension assay, you have two matched antibodies that are labeled with DNA oligonucleotides that then bind to your target protein, those antibodies, and then the DNA oligonucleotides then hybridize, creating this DNA barcode that's unique to each protein. And so this has really enabled these large-scale population cohorts to do proteomics on a really high scale. So these technologies tend to be quicker and more cost-effective. And some of the newer technologies, like the SomaScan 11,000, can actually identify up to 10,000 unique human proteins in plasma. So why measure the circulating proteome? What are some of the main uses for population-based blood proteomics? Well, you can use it for the discovery of genetic variants that are associated with protein abundance. So this allows us to connect genetics to disease pathways. We can also use proteomics to identify possible mechanisms of action and protein-protein interactions associated with specific diseases. We can identify novel biomarkers of disease, novel therapeutic targets, and then what I'm going to be focusing on the rest of this talk is that we can use population proteomics to improve disease risk prediction, which also potentially will allow for patient stratification for clinical trials if you're trying to target a higher risk group. So why do we need proteomic risk scores for lung health at all? Why can't we just use sort of clinical models? Well, we really don't have, there really aren't any widely used clinical models to predict chronic lung disease at this point. So this table here is from a systematic review by Matheson and colleagues back in 2018, where they were trying to identify clinical models that predict incident COPD. I excluded one, which was just done in people with asthma. And you see here that, based on the positive and negative likelihood ratios, that they do help us improve our prediction of incident COPD. However, there are some issues with these clinical prediction models, one of which is that often in a lot of these, the only modifiable risk factor is smoking. And as Dr. Moll had mentioned, up to 45% of people with COPD are never smokers, and only about 30% or maybe up to 40% of smokers will then develop COPD. So really that leaves us wondering, what else can we use aside from smoking history to better understand somebody's risk of developing lung disease in the future? And then some of the models that do include additional modifiable risk factors are things that often the patient won't know. So like the model used by Guo and colleagues in 2015 include a history of childhood respiratory illness and low birth weight, which most patients won't really know and can't contribute. So instead, can we use a blood test to identify people who have increased susceptibility to chronic lung disease? So I'm going to go into a few examples of proteomic risk scores. This was a proteomic risk score of increased respiratory susceptibility that was published by our group just earlier this year. And so I'm going to go through in a little bit more detail our methods, which are really the methods that are used for a lot of these studies that generate proteomic risk scores in lung health. So for this study, we used the cardio cohort, which is a population-based US cohort. And then we examined plasma proteins at mean age 50 using the SomaScan assay. And then the primary outcome that we were looking at was accelerated decline in lung function trajectory. And the reason that we looked at this is because we know that, and a lot of studies have shown that accelerated decline in lung function is associated with future COPD, future respiratory exacerbations, future respiratory morbidity. However, really this, again, is not something that's practically used in the clinical setting because it requires multiple lung function measurements over the course of, years to decades. So in this study, we used a lasso regression, which is a regression model that applies a penalty to variables that reduces overfitting and allows for a variable selection. And this is what you'll see in a lot of these proteomic risk scores and proteomic signature studies. So we use this lasso regression to essentially find the group of proteins that best predict our outcome of accelerated decline in lung function trajectory. And then once we had that model, our susceptibility score was calculated as the sum of the scaled protein level multiplied by their lasso coefficient. And what we found was that our risk score was associated with incident COPD and respiratory exacerbations in two separate testing cohorts. So in UK Biobank, we were able to look at incident COPD, and we found that people with the highest quartile of risk score had a nearly 4 times higher risk of developing COPD than people in the lowest quartile. And then within a sort of high-risk population like COPD gene, we were able to find that people with the highest quartile of risk score had a 33% higher risk of incident respiratory exacerbation and a 54% higher risk of incident severe exacerbation requiring an ED visit or hospitalization. We also found that in both cohorts that our respiratory susceptibility risk score was associated with increased risk of all-cause mortality and respiratory mortality. And we essentially found similar results when we restricted the cohorts to only those without baseline lung disease, including asthma, again suggesting that in the future, this could be something to apply on a population scale to better understand risk of developing chronic lung disease and sort of poor sequelae from those respiratory diseases in the future. We'll go through a couple other examples of proteomic risk scores in lung health. This was from Justin Oldham and colleagues that was published last year. They developed a proteomic risk score of IPF transplant-free survival, and with just 96 proteins, they were able to predict transplant-free survival in IPF cohorts with an impressive C statistic of 0.86, which outperformed the clinical model. And in the decision curve analysis that you see on the left there, you can see that the proteomic model in red performed similarly well to when you added the proteomic model to clinical factors in blue, light blue, and then both of those models performed much better at any threshold possibility compared to the clinical model alone, which is in the sort of navy blue. And then you can see when they compared the proteomic model to the clinical model that there was much greater discrimination between quartiles of risk in predicting transplant-free survival. And then Willis Bowman and colleagues back in 2022 developed a proteomic risk score of progressive pulmonary fibrosis. And with, again, just 12 proteins, they had a sensitivity of 0.9 and a negative predictive value of 0.91 to predict 1-year ILD progression in people with non-IPF ILD. So what you can see in the graphs there is that compared to people who were deemed to be low risk based on their proteomic risk score, those who were deemed to have high risk, to be high risk based on their risk score, had significantly more decline in their lung function compared to the low risk people. And this is really important because, a subset of patients with non-IPF ILD will have this progressive fibrosing phenotype. For example, about 40% of people with RA-associated ILD will have progressive fibrosis, but we don't know who are those 40% of people. And so if we can have a proteomic risk score like this, this may allow us to identify progressive pulmonary fibrosis earlier, which often leads to a real change in management in this disease because you end up starting things like antifibrotic medications. So just to summarize, some of the advantages and promise of proteomic risk scores in respiratory health, this unbiased discovery-based proteomics techniques can uncover novel proteins relevant to lung health to reveal relevant pathways in lung disease pathogenesis. And these proteins are impacted not only by genetics, but also by environment and lifestyle. So it may allow us to identify a modifiable biomarker that can offer the opportunity for intervention, i.e. finding something like the cholesterol of the lung. And in general, these proteomic risk scores perform better than single protein measures. But some of the limitations are that we really have a very limited understanding at this point of longitudinal changes in these proteomic scores. Nearly all of the studies that I've presented have been cross-sectional, and these protein levels can change hourly or be influenced by sort of even seasonal and environmental changes. And again, because we're looking at the circulating proteome, it might not be lung-specific and could be influenced by non-causal factors. And ultimately, we still need a better understanding of which of these proteins really have a causal role. So I'll end there since I'm over time, but these are some of the folks that I've worked with, and yeah, thank you.
Thank you so much. That was fantastic. Next, I have the honor to also introduce Dr. Victor Ortega. He's a professor at Mayo Clinic, pulmonary disease specialist and genetic epidemiologist with over 20 years of experience. He leads the genomics research studies across multiple different networks funded by NIH, the National Heart, Lung, and Blood Institute, focused on how variation in individual genes can influence or alter the risk for more severe asthma, COPD, emphysema, and impaired response to commonly used drugs. He also directs the Center of Individualized Medicine in Mayo Clinic, Arizona, and leads the enterprise-wide effort to implementation of polygenic risk scores and testing of rare Mendelian variants for respiratory disease. Currently, he's appointed member of the ATS Genetics and Genomics Program Committee and the Assembly of Allergy, Immunology, and Inflammation Program Committee. Thank you, Dr. Ortega.
Thank you very much, and yeah, happy to present today. And thank you for the kind introduction, Rodolfo. I appreciate it. So I'm going to talk a little bit about idiopathic pulmonary fibrosis as a disease case for the implementation of polygenic risk scores. My disclosures: I'm on an IDMC I used to be for Regeneron and Sanofi on an IDMC. I'm an associate editor for JAMA, and I'm an author on UpToDate. So there's been several over 22 genome-wide discoveries for idiopathic pulmonary fibrosis. Some of these relate to pathways that we've known about in familial disease, like telomere biology, and then the MUC5B was a pretty amazing discovery as a common variant with variable penetrance but strong effects. This is at the time was the largest discovery, GWAS, for idiopathic pulmonary fibrosis, published by Allen and colleagues, which looked at over 2,600 cases of IPF on 8,000 controls and identified 16 variants that reached genome-wide significance, of which 5 were novel, and 5 of those novel variants, of which 3 were replicated. These summary statistics, as mentioned by Matt Moll in his initial talk, are what really goes into the development of these polygenic risk scores, as many of you probably know, but more for those of you less familiar. You take these summary statistics and you use with a lasso sum regression, as a second speaker, Gabby, talked about, and you generate what is a polygenic risk score. And this was done by Matt Moll and colleagues in 2023, and published in the Blue Journal, taking these summary statistics and developing a 60,000 plus variant polygenic risk score, which was looked at with a strong MUC5B variant, but also without it, in a total of 14,600 participants. And this was very strongly, and this was obviously very strongly enriched for a more definitive diagnosis of what's called idiopathic pulmonary fibrosis. And then they also tested for associations for interstitial lung abnormalities and COPD gene, Framingham, Mason, spiromics. And you can see here in the Denver cohort the distribution of a polygenic risk score, normally distributed. And you can see here with the upper quintile and a twofold increased risk of having a diagnosis of idiopathic pulmonary fibrosis. So a very strong predictor of risk for idiopathic pulmonary fibrosis identified with this polygenic risk score. And it performed very well. This was without the MUC5B locus. If you add this, the predictions are much stronger, but you have to look at it independent of it, just because of how strong that individual locus is associated with IPF risk. If you looked at interstitial lung abnormalities and 2 of the COPD cohorts in Framingham Heart, it was also significantly associated with interstitial lung abnormalities, which are these less clearly defined changes in lung that do not meet the diagnosis of IPF. The MUC5B variant also had a strong association with interstitial lung abnormalities across several cohorts. I think as we get into the exciting world of polygenic risk scores, we do have to take a look back and understand that we cannot miss the contributions of rare Mendelian variants. We cannot overlook that important contribution as we move forward in this. And as we talk about multiple GWAS variants with smaller effects that go into a polygenic risk score, looking at rare variants with larger effect sizes that are less common in the human population are tougher to do in a large scale, because it requires sequencing or more dense genotyping, and there's ancestry-specific variation that also could be missed if you don't do sequencing. I think this actually is a nice figure that I had the opportunity to work on with Alan for an editorial, and it shows the different allele frequencies of loci that cause idiopathic, sporadic, and familial pulmonary fibrosis. And it shows similar as the last slide, the more common variants with very low effect sizes, the MUC5B with an exceptionally high effect size for a common variant, and then the rare variants and telomere, biosynthetic pathways, surfactant protein pathways, these Mendelian familial variants that have a large effect. There is overlap. I mean, TERT and TERK, the two telomere genes, TERT and TERC, also have common variants from GWAS, but also are variants that are associated with familial cases. Telomere length is an example of an additional omic measure that we would have to consider in looking at profiles for genomic risk. And, as we see here, are associated with lung function, also associated with survival, greater than 10th percentile, telomere lengths having lower lung function, and then across the quantiles of different telomere lengths with increasing risk for death or risk with transplant-free survival. So how does something like telomeres and telomere-related pathway genes act in combination with other genes? That's a question I'm not going to answer for you guys today, but it's a thing you have to think about when you're developing programs to look at genetic risk or using genetics as a tool to understand risk and prognosis. At the Mayo Clinic, I lead the center in Arizona, and we've expanded. There's over 20 different proud clinics from the program of rare and undiagnosed diseases. In Arizona, we've expanded our numbers to have over 6. There's actually more than 8 at this point. I'm developing clinics where we optimize genetic testing. 2 of them are lung focused. I lead the airways bronchiectasis alpha 1 clinic, and then we have our interstitial lung disease clinic, which I also work very closely with. And we've been recruiting patients there, and those patients are seen by a genetic counselor. We have a team that tracks results. We have databases that store the results, and we have genetic counselors who help find the best testing and then help the patient pay for the testing and then go over the results. It's all done with CLIA certified DNA sequencing. For IPF, we sequence 37 genes, and we do it on a whole genome backbone that we can go back to generate PRSs with. In a subgroup, we do telomere lengths as well. And I think this is important, and this is the experience in Rochester. The numbers here are clearly double because we also have the clinic in, and I'm sorry if I keep looking back at my timer. We have probably double the patients, but just this is unpublished data, so please handle with care. But we've identified pathogenic variants, and of the 54 patients who consented, we've identified variants that are pathogenic in about 20%. So 1 out of 5 patients have something there, and it's mostly in our telomere biology genes, RTEL1, TERT, and TERK. You can see 8 of the 10 variants that we found were in telomere biology genes, and 60% of our patients that we tested had low telomere lengths. What is the effect of those cumulatively? Who's to say? From a genome-wide perspective, we also have the Tapestry study, and that was launched in 2020. And we will have genome-wide data on over 100,000 patients across the Mayo Clinic enterprise, which includes Florida, Arizona, Wisconsin, and Rochester. We have data on over 52,000 patients to date, and we recruited over 1,400 Hispanic Latinos, and around the same number, if not larger, of African Americans, and a lot from our Florida site. And I had the opportunity to lead the lung sub-study of this, which looked at essentially every patient that came in for PFTs across the Mayo enterprise was screened or was provided an opportunity to provide informed consent. And you can see the large numbers we've accrued with the first 75,000 patients who came into the study, over 8,000 with asthma. And the numbers here kind of speak for themselves, 2,500 with ILD, over 700 with bronchiectasis. We expect those numbers to be higher because of the enrichment, because we really kicked the recruitment into gear through 2023. This is some initial unpublished data, and relax, Matt, I'm not showing anything else but this, so just relax. We confirmed the IPF signal and also found an ILD signal here in our IPF Tapestry. We had 3,000 patients with ILD and over 800 with IPF in our Tapestry cohort, and we did a good job of replicating. These are the quintiles compared to reference, which is the first quintile, and a substantially increased risk. And we're looking into other outcomes as well that are more related to disease progression as well. But just wanted to show you that we were able to validate it. And for the sake of time, I'm going to be very brief about this, but there are other NHGRI-funded polygenic risk-focused programs. One is eMERGE, where they want to look and validate implementation of polygenic risk scores in 25,000 people, of which they published their experience in the first 2,500. And then there's PRIMED, which wants to look at and develop polygenic risk scores across a diverse population spanning 120 data sets over 45 countries to improve its applicability. This is some of the preliminary work on the first 10% of the patients who came in where they developed a polygenic risk score panel. They wanted to look at 23 initially as candidates. Once they went through analytical viability, feasibility, clinical actionability, and translatability, and they went on to their phases of optimization, went on to looking at application across variable ancestries, uniform phenotyping across their diverse cohorts. They ended up with 10 of the 23 that they looked at in this preliminary study. And what's important here was that they took genotyping data from the Global Diversity Array from Illumina, and they did imputation to generate polygenic risk scores. They looked at 13,000 patients from all of us to calibrate the polygenic risk score, accounting for diverse background ancestries, and then they came up with a clinical report to return to the patient. And you can see here that they selected these different diseases below here that had nice associations across the different diseases. They picked nice high polygenic risk score thresholds. Their scores span hundreds to tens to hundreds of thousands of SNPs, and the disease obviously impacted a range of ages. So what were the challenges that were addressed by eMERGE in this study that they showed for the first 2,500 patients? They developed a CLIA-certified, cost-effective PRS. They did calibration to account for diverse ancestral backgrounds, and they provided an output for clinic based on set risk thresholds. What did they not do? What has yet to be done? Integration of Mendelian variants, overlapping sequencing, a platform adaptable to more diseases, more rapidly applicable. There's hundreds of polygenic risk scores. Development in increasingly uniform data sets, not just projecting and doing statistics, but actually testing them in the data sets where environmental factors and socioeconomic factors are important. And then predictions beyond case control. I think we're interested in case control, and that's how these things are designed. But in the end of the day, we want to know how it impacts outcomes that we can address on disease progression. Uniform reporting is also important, and then considering clinical context. How do we develop studies that consider clinical context? In our center, we lead the polygenic risk score framework for the enterprise. So we have developed and are developing continually a framework for implementing polygenic risk scores. We're piloting it in ILD and have developed plans for reporting and clinical implementation. These are the 4 work streams, and I don't want to go into too much detail, but just to know in the red, we have the ability, because we'll have over 100,000 patients where we have uniform phenotyping. We're not going across multiple cohorts to harmonize and lose detail. We can look at comprehensive phenotyping in a different way. And when we come into clinical display and implementation, we have the clinical resources to report to patients our results. We also have a way to prospectively study disease through our GTAC clinic program and retrospectively evaluate using Tapestry. And, we picked IPF because of its interesting combination of rare variants from Mendelian disease and polygenic risk scores. And I've showed you 2 examples of a clinical implementation framework that will be based on these 2 things. A center program where we can provide results. We have background whole genomes in these patients already when we do their Mendelian gene testing. So we have it already. So we'll generate the polygenic risk scores, and we're going to perform a study to look at outcomes in a prospective group of 80 to 90 patients, but also in our 800 patients in our Tapestry, which is our large genome-wide platform that we have as well in Mayo Clinic, and it enables us to collaborate with other external partners as well. And I'm sorry I went a little bit over, and I thank you for your time.
Thank you so much. That was wonderful. And now I think this section of the webinar, I would like to invite all 3 speakers to share their insights on certain questions. Emma Matters asks, well, thanks you for a wonderful presentation. And she's asking if you could talk about the difference in costs between standard PFT testing and proteomics risk scores. I'm guessing we're talking about COPD and how that relates.
Yeah, I think that's a really good question. And I think a question a lot of people are asking, in terms of the costs associated with spirometry, I think one thing to consider is that, again, we have so much of, these amazing population studies that have shown us how important lung function trajectories are over the life course. But again, that requires us bringing in healthy people, testing their lung function at multiple time points over the course of years or decades, which, again, it's not really happening in clinical practice. And, I think the U.S. Preventative Service Task Force has suggested against doing spirometry in healthy people. So certainly not something that's sort of recommended at this point. And so I think, that's on the one hand, the cost of performing spirometry serially, and then comparing to, the cost of a blood test. So, I think it is really important to try to get down to exactly which of these proteins in these larger proteomic risk scores are really the most relevant. So, in the study that we presented, our proteomic risk score had 32 proteins, but some of the work that my mentor, Ravi Calhan's doing, and he's on this call here, is looking at the top 20 proteins, and can we actually do quantification rather than just, because right now, a lot of these proteomic risk scores are really based on the relative quantity versus other proteins in a population, but can we actually get an absolute quantification of, say, the top 20 proteins and really figure out which of these one, can we use a smaller group of proteins, and two, do some sort of, more mechanistic studies to figure out which of these proteins really might be on the causal pathway and leading to disease. So that's two, trying to, again, narrow the focus, narrow that group of proteins. But some of the data I didn't show was there are some papers by, I think it was Zarasco, Carini and colleagues that were published in Nature Medicine last year. And they were able to look at like the top 5. They did proteomics and then looked at the top 5 proteins associated with about 67 different diseases, and found that even as small number of 5 to 12 proteins, they were able to improve prediction compared to just clinical models. So I think it is important to get to these, to sort of narrow down how many proteins we, which ones are the most important, so that it can be more cost effective and used sort of in a healthy population.
Thank you very much. That's quite interesting. I was looking up actually the cost of a PFT is around $500 something average across the US, and I'm understanding that the omics test, it's a blood test, a swab can be $30-$40. So it should, if I'm correctly, if I'm correct on this should be a fantastic way of screening and saving money to a system.
Yeah, I agree. Especially, if we can get down to a smaller number of actual things that we're testing. Because, the actual proteomics that we're doing here, testing 7,000 proteins, that costs a lot of money. But once you can get down to, say, 10 proteins, that's going to be a lot cheaper.
I will also just make a comment that spirometry, it would be really interesting because there's a lot of data about bronchodilator responsiveness predicting FEV1 decline, whereas your proteomic work, right, is predicting trajectories and exacerbations. Like, it seems like you can get a lot more with a lot less. So I think there's the cost effectiveness aspect, but even comparing it to bronchodilator responsiveness, just looking at your numbers, I would bet that it might be as good or better than that too. Anyway, I don't know if you've already looked at it, but anyway.
Yeah, we haven't done a true cost analysis, but it is a really interesting question.
One of the discussions that I was having with some colleagues was about the cost benefits that hospitals and healthcare bring that are just not quantifiable. If you have somebody that is going to have a disease that progresses, or unless you intervene early, you can keep them on the workforce, you can keep them producing, you can keep them contributing, as opposed to being chronically ill and not able to contribute.
Yeah, certainly. That definitely, I think, needs to be factored in. Yeah, if you're actually able to sort of prevent disease and, use this for primary prevention, that could have an enormous impact.
So with that in mind, and this is open to anyone, any of you, it's when should clinicians start considering the using these omics or these tests?
That's a toughie because most of them are developed based on case control status. That's the basis. That's been the challenge of getting this thing onto prime time. Once somebody comes in with IPF, the reason why we thought it'd be useful to have a polygenic risk score implemented and developed, and we're actively doing it, is because number one, we think that it might be an additional diagnostic tool that can help you when you're making decisions about whether or not you want to do a biopsy on somebody who already has impaired lung function. The sooner you get a diagnosis, the sooner you can start antifibrotic therapies. The other questions that remain to be seen with analysis is, does this IPF PRS predict mortality or transplant-free survival? What are the things that it does in terms of that? That has yet to be seen. Those are the kind of analyses that are additionally informative. And I think, in a data set like Tapestry, because we're not harmonized, we're going to have 100,000 people from the same health system. You can look at a lot of things. So you can look at a lot of phenotypes there in a uniform way without having to. They'll probably run into these networks, right? Is because we're bringing in different sites with EHR data, because that's really where the big data is coming from, like All of Us or UK Biobank. You have to really reduce it down to the common data available across all your different sites, and that reduces the detail. And that's an issue with eMERGE and other networks as well, because they do develop their phenotyping on an EHR framework. We don't have that issue, and there's been a lot of investment with Google Cloud and Microsoft to really develop our data. So if you look up Mail Platform, that's our phenotyping platform data, our multi-tenant platform. We're also integrating lung function data. We're going to be integrating radiomics data. You can do all these things. And I think it's really not about, I guess what I'm trying to get at is trying to get beyond case control. How are we going to prevent, how do we prevent asthma? Do we tell kids not to get viral infections? I think the question that's more interesting is more what Matt alludes to, is really when you partition the polygenic risk scores, what are the polygenic risk scores telling us about the subgroups of asthma? I think that's more relevant for asthma. For IPF, it's about a similar question, but also about trying to get diagnosis. For COPD, one could argue that you might want to know your risk, because then you can identify patients and intervene early. That might be important there, but also maybe you want to put down that cigarette. There's things you can do. I think it really depends on the clinical, and that's why I mentioned clinical context is so very important when you're looking at different polygenic risk scores. And until we really understand clinical context beyond the case control models, I don't think that most of your polygenic risk scores, at least the ones in respiratory medicine, are ready for prime time until we can get down to brass tacks on that. And that's the basis for our framework at Mayo Clinic, is leveraging our resources to get a clinical context, and not, and not try to do 100 diseases at once, but try to understand each disease individually in a way that actually will impact outcomes. I think that a lot of when you see things that come out on CDC Tier 1 and ACMG rare variants, it's really, did it change intervention? That's cool and all, but that doesn't move the needle on the things that matter downstream. And what does it really do? And I think I've just said a lot, so I'll stop there.
No, I really appreciate, Ortega, that you also just happened to sneak in the answer to the title of the webinar. So that was very, very smooth. Thank you. Then with that in mind, if I can ask you, I heard some of the lectures that I attended on cutting edge technology in healthcare, they said that is from the moment that it gets tested and it's almost ready to the moment that it's actually able to be widespread implemented, it takes about 10 years. Very difficult for any of you guys, as smart as everybody, all of you are, to predict the future. But what's your best guess of when would this be really available?
Yeah, I mean, I guess I would say I wouldn't be surprised if it was 10 years. I think that's it's always possible. But I think the stuff that like Vic is showing with the infrastructure that they're building at Mayo and having CLIA certified tests that people can order, right? This is addressing a lot of the barriers. So I think there's regulatory barriers, there's infrastructure barriers, there's paradigmatic barriers, right? So like, the infrastructure barriers are kind of what Vic is setting up and addressing, right? How do we actually create a framework where we could use these kinds of things? And it's that same framework, I imagine, would be useful for proteomics and transcriptomics and other kinds of multi-omics in the future. So I think it's really important foundational work. It's also far advanced, I think, compared to even some of the cardiology work where, like, for example, like LPA has been used clinically and they recommend using polygenic risk scores without any real guidance. But now, several years later, LPA is coming out with a LPA directed therapy, right? And that trial was published, fairly recently. So, it's sort of like how much do we have to know before we start using something and then getting data? And I think the cardiologists are more liberal than we are. They're more like, we're going to put this out there and we're going to gather more data and we're going to learn more. I think we're on the conservative side, and I think but having this infrastructure to help bridge that gap and move it forward, I think, is critical. The regulatory aspect is that we need to really work with, if you want an FDA-approved biomarker, getting the FDA on board earlier, getting people who know how this works, because I don't know how this works, right? I think that's really important to speed implementation. And then there's the paradigm aspect, right? So what is our schematic? How do we think about this? Are we thinking about the fact that we can order a blood test to help with diagnosis or prognosis for a disease? And that's where, things like this webinar are really important to help us understand what's out there and push the thinking forward so that we can also, feed back into the regulatory and the infrastructure aspects. So that's, I guess that's how I think about it. But
yeah, I mean, as long as we're still spitting out statistics that say you have a 20% chance of something, like you have a 30% chance of wanting to drink red wine, that doesn't move the needle. It really is going to be something that gets in front of the provider and provides very clear, like, this is the risk, this is what you do. And that's why cardiovascular PRS, are being touted by the American Heart Association. You need to use it, but okay, you have a high risk, then what do you do? I mean, there's suggestions that statin therapies are more effective in these folks. And so we're getting there, but until those things are in place, this is just it's going to be a tool that kind of just gives you risk and doesn't get you beyond that. And I think but yeah, so that's where this framework is important. In studies, developing a test, validating the test in a perspective, you have to have infrastructure for all those things. That's the kind of, when I showed you the GTAC clinic and, and what will the FDA accept if we have 20 years of longitudinal data and tapestry already retrospectively? Will that be acceptable data versus running a longitudinal study where we're using whole genomes in a smaller setting, in a more controlled setting? I imagine that the former would be more relevant in a disease like breast cancer, where we already have these randomized studies. You already have studies that are ongoing. And that's one of our next ones, is breast cancer, because there are active studies. There's a nice polygenic risk score. We kind of know the role of hormonal therapy there. There you might not have to do so much rigorous testing because the trials are being done to bring that on prime time in an FDA panel, versus IPF, where, we still have to do the study. We still have to do a study that would make FDA happy, while developing a test that is rapidly expandable and can be sent around and is sensitive to different ancestries. I mean, there's a lot to disentangle when you talk about a product that's ready for prime time.
Yeah, and I will say there is a proteomic risk score in lung health that's related to non-small cell lung cancer. So I do think like these smaller groups, yeah, thinking about like cancer and thinking about, these smaller groups of patients that, are probably easier to sort of get things actually moving, and certainly things I think move quicker in the oncology realm. But yeah, there is this proteomic risk score in people with non-small lung cancer to predict sort of good or poor response to EGFR inhibitors. That was shown that, people who have this sort of poor response risk, who are in this poor response risk group, really did quite poorly on EGFR sort of monotherapy, inhibitor monotherapy, and then later showed that with other sort of immune checkpoint inhibitors, they also did worse with immune checkpoint inhibitor monotherapy compared to traditional chemotherapy. So, and I think they sort of came out with their initial studies in 2007, and then it was sort of commercial in 2014, and they were studying it in sort of phase 3 trials and things. So, yeah, it's still certainly, I think, 10 years seems like a reasonable time frame. Yeah.
Fantastic. Thank you so much. I believe we are at time, and I want to thank again all of our speakers for such an interesting lecture and the clinical problem assembly on ATS for this webinar. Thank you very much, and this will be posted on YouTube for people to share and follow it. Thank you.
Thank you very much.
Right.